Hello everybody, a really warm welcome to Community Connect at the Union. Thank you so much to EGPAF and to Treatment Action Group for organising this session in which we're going to talk about the impact of civil society and community work for demand creation and the monitoring of TB services. I'm really pleased to be co-chairing today with Blessy Kumar from the Global Coalition of TB Activists. My name is Danielle Ferris and I'm working with the Global Health Agency UnitAid. At UnitAid, we champion equitable access for innovative health solutions that are not only fit for purpose, are made more affordable, but are also more rapidly available for those who need them the most. UnitAid continues its strong commitment and investments in TB, including in prevention for new detection tools, but also in the adoption of new treatments. Our programs include working with community and civil society partners who play a significant role in our funded projects, but are also instrumental in contributing to the impact and success of our interventions. Our strategy reflects the importance of demand creation and community-led approaches. In this session, we're going to hear from a number of speakers that are going to present examples and experiences of building demand for and the monitoring of implementation of TB services. Our speakers include RT from CASO, who's going to speak about the global targets, but also Global Fund's role in demand creation and community-led monitoring. Keitha from the ARC Foundation is going to speak about building community demand for the uptake of TPT, with examples from the UnitAid funded project Impact for TB, as led by the Aram Institute. Pappy, who's the care focal point for EGPAF DRC, is going to be talking about addressing the inequities faced by children in the TB response, and also the role of CSOs in monitoring childhood TB policies at the national level. Edna from COLA from Malawi will be talking about improving access to and the quality of diagnostic services through community-led monitoring. And finally, we're going to hear from James from the Stop TB Partnership, who's going to be talking about investing in CSOs to end TB, with a review of the challenge facility for civil society. Thank you so much. Enjoy the session.
Hello, greetings everyone. My name is Keto. I'm happy to be here presenting on an initiative that we have done in India under the Impact for TB project. The title of my presentation will be Building Community Demand for the Uptake of TPT in India. We've initiated our TPT advocacy project under the Impact for TB project way back 2 years ago. And in all these activities, we have put enough investment as far as engaging the community is concerned. We have used certain strategies like empowering the community with knowledge informations by building their capacities on TPT, therefore with the hope that the demand for a better TPT can be generated in India. And this is how we have actually worked upon the CLM approach. And the objective of this was to assess, identify, and report on TPT, its availability and the quality of TPT, but also including the preference of TPT courses, as in compared to IPT, for example, with 3HP. Our CLM approach was done over a period of 5 months and engaging 207 as respondents from the PLHIV background and in 5 states. It clearly stated that the final report mentioned a preference of 3HP among these populations as compared to the 6 months regimen of isoniazid preventive therapy. The report shows that 77% of the respondents were literally not aware of what LTBI is all about. 55.6% of the respondents had not taken IPT because of reasons like the fear of side effects, pill burden, the resistance, the not a conducive environment, distance factor, and the fear of identifying themselves, or rather getting themselves exposed as a PLHIV person if they were to be initiated on IPT at the ART centers. And out of those who have not taken TPT, 70.9 of them responded that they were literally not informed about IPT as well. Of those who have taken IPT, 21.1 were still reluctant to take it. Now the CLM volunteers also reported that it may be likely that they might have got themselves registered, but when it comes to actual intake of the IPT for 6 months, they might not have taken it. They might have, of course, taken the drug, but it could so happen that they have thrown it away. 62% of the respondents were not screened of the verbal communication screening method of 4S, nor pre-test and post-test counseling was given to 66.1 of those who have taken IPT. It also shows that many of them, as in 87% of them, have not attended any sort of meetings, trainings, seminars on TB. Therefore, 88.9 reported that they have not even heard of GHP regimen. 73.4 of the respondents believe that treatment literacy is very much required, and if it is made available for them, they would definitely love to attend it. 88.9 of the respondents says that advocacy and training on TB and TB prevention therapy is very, very important, and that they definitely need it as well. Further, 80.2 of the respondents agreed that 3HP should be given as a good as a as an option for TPT through state and the national program. So all in all, the advocacy for a better short course regimen continues. What we have in store for now in terms of our present acts is that there should be a national rollout program for 3HP, and that treatment literacy should be provided now, not only for the high risk group, but also for other high risk group as well. And to include the provision of vitamin B6 as part of the present TPT course is concerned, or even if the 3HP is rolled out as a national program, pyridoxine should be provided as a complete treatment package for this. And to acknowledge the importance of community involvement, to ensure that a robust community involvement is integrated by the national program so that the community can play a key role as far as supporting the program and as far as uh, uh, upskilling the service of TPT in India is concerned. Thank you all very much.
Hello, every organizer and attendees. I'm Dr. Papinjibu, TB specialist at the Elizabeth Glaser Pediatric AIDS Foundation, ECPAF DRC, with more than 10 years of experience focused on controlling the HIV/AIDS and tuberculosis epidemic in the DRC. I'm pleased to share with you DRC example regarding inequity faced by children in the TB response. Indeed, according to the WHO Global TB Report 2018, DRC were one of the 2020 TBI burden countries worldwide, and in all three WHO lists for ITB prevalence countries such as TB only, TB HIV, and MDR TB. Nevertheless, despite a sharp prevalence and low pediatric TB notification rate, policy on pediatric TB were still lagging behind. In order to address this challenge, CAPTB, in collaboration with the NTP and local CSOs, worked to improve them from 2017 to 2021. And to achieve its objectives, CAPTB project is implementing some key activities such as selection of CSOs to implement community-based pediatric TB activities and signing of the contract, training of CSOs staffs on pediatric TB advocacy, provision of grants to two local CSOs I quoted CAD and LNAC for implementation of pediatric TB advocacy activities, DRC policy landscape 2018 and 2021, technical support of CSO staff such as training and refreshment, close supportive supervision, monthly and quarterly activities and data review with remediation. And as achievement, contrary to the findings in 2018, by 2021, new policies recommended regarding festival integration, the integration of all TB services from TB screening to TB reporting to the NTP in maternal, newborn and child services and also in general outpatient department. New policy recommended also integration of TB screening in nutrition services. Regarding case funding, new policies recommend household and close contact of index TB, case tracing and screening for active TB, periodic systematic active case funding for pediatric TB in defined settings such as school, street, child, refugees, and congregated setting. Regarding diagnostic, new policies recommend the integration of ultracardiography for expert MTB RIF, chest X-ray in diagnosis algorithm in children, TB lamp for pediatric TB diagnosis in children living with HIV severely sick in IPD and with symptoms if CD4 less than 100 in OPD. Regarding treatment, new policies recommended pediatric dispersible FDC and ethambutol 100 DT, all oral DRTB regimen for children, use of new drugs such as bedaquiline and delamanid in children, use of dolutegravir in TB HIV co-infected children regardless of weight. And after implementation, we have learned that CSO's involvement in advocacy is essential for policy and guideline updating, improvement of service coverage and access, and increased funding in order to address pediatric TB catastrophic costs and inequity. Capacity building of local CSOs is critical for policy updating and monitoring. Strong collaboration with local CSOs is key for monitoring, for policy monitoring and demand creation of TB services. Before ending, I would sincerely thank the DRC National TB Program and Ministry of Health, the World Health Organization, United, local CSOs I quoted, CAD and LNAG, CAP-TB Global Team, and ECPAF HQ. Thanks.
Good morning, good afternoon, good evening, wherever you are. My name is Edna Tembo, working with Coalition of Women Living with HIV and AIDS in Malawi as the Executive Director. I have no conflict of interest to report. My presentation is going to talk about the impact of civil society and community work on demand creation and monitoring of TB services. First of all, I'll start to talk about the roles of the civil society in demand creation. Civil society organization, we play a crucial role in demand creation, and we are also an important source for data for the communities. As Malawi civil societies, we have managed to influence policy and hold government accountable to and the implementing partners. We have also engaged in advocacy and enhancing community human rights for the recipients of care. We are also involved in doing community-led monitoring, whereby we monitor the work that is done by government, private sectors, and other implementing partners. And we also had a role in building capacity of the communities so that they are able to understand our advocacy and help us in the demand creation. During our demand creation, we utilized opportunities at national level, whereby we were involved in the revision of policies. For example, the clinical management of HIV, where we influenced the 3HP to be a choice of TPT, and also to increase the TB diagnostic test platforms for especially for the PRHIV. And we have also been involved in the technical working groups, whereby we have advocated for TB services, especially increasing the diagnostic molecular platforms and scaling up of TPT to all the districts. We are conducting community-led monitoring, which we have also included TB, TPT, and the diagnostic test as indicators so that we are able to follow up on what is happening on the ground. And we have worked with the various stakeholders, for example, the media, religious leaders, parliamentarians, in order to increase the voice in demand creation. At community level, we have also made sure that we work with the people affected with the disease and also the support groups. As COLA, we work with women living with HIV who are in support groups, and we have made sure that we train them to understand the treatment literacy, as well as how to conduct demand creation at community level. So these women have also supported us in demand creation, going to the communities, doing community awareness and campaigns, and also conducting community-led monitoring to help in identifying issues which were brought forward, and an advocacy was done to create demand as well as also to address the identified gaps. We have also linked the expert clients who were involved in health education at outpatient departments, as well as also in community mobilization, whereby they also had to work with the CSOs who are doing TB services and conducting collaboration meetings so that demand creation was done at community as well as facility level. An example in one of the districts whereby the provider Bella were doing service provision on HIV and TB, and they collaborated with COLA support groups to help in creating demand, which helped bring in more recipients of care to access services. The challenges which we met as civil societies advocating for TB services was the rollout, which was delayed due to inadequate quantities of 3HP that was procured in the country, and the identification of impurities in one of the first batches that was delivered in the country, as well as the policies which were restricting, and also the identification of household contacts and tracing, and the fear which was there amongst the community who especially faced side effects due to IMH. And the lessons that we learned were that working with the communities is a game changer. because the communities were helped in creating demand, and they also exerting pressure and influence to the policymakers, as well as they were able to make proper follow-ups since they knew each other from the support groups, and brought those who have interrupted from treatment back to care. And we also learned that working with women is a game changer as they reach out to the greater number in their facilities as well as in their families. And they are able to identify issues as the caretakers. Thank you very much. My acknowledgement goes to Impact for TB through TAG for the financial support, Malawi government and other partners, and not forgetting the community members who helped us in the demand creation and made our goal and made us to achieve our goal. Thank you very much for your attention.
Thanks so much, Danielle and Blessy, for that introduction. Also just wanted to acknowledge all of the speakers who have spoken before me on this panel. This presentation is very much looking at investing in the TB-affected community through Challenge Facility for Civil Society. Challenge Facility for Civil Society is a funding mechanism which facilitates investment, technical assistance, and capacity building for TB-affected communities and civil society. This mechanism promotes an equitable, rights-based TB response and has a particular focus on social accountability, advocacy, demand generation, and community participation. The recently announced Round 11 Challenge Facility for Civil Society has 100 grantees from 28 countries sharing a pot of over $10 million US. This is thanks to funding from USAID and the Global Fund. However, TB communities in the report entitled A Deadly Divide, TB Commitments vs. TB Realities have called for more donors to step up and close this funding gap for TB communities. Challenge Facility for Civil Society has supported the development and utilization of a number of tools that have supported building an evidence base around human rights and gender-related barriers to TB programs. We hear a lot about finding the missing people affected by TB, but we know the reality for many of these people is that it's human rights-related barriers that are inhibiting them from accessing the prevention, the diagnosis, the treatment, and the care that they actually need. In a recent analysis of over 20 national TB CRG assessments, a number of issues came to the fore. But three that have stood out and are really relevant to the discussion today include TB, stigma and discrimination, and breaches of privacy and confidentiality as a prevailing theme in many countries with high burden of TB. Second, the availability, accessibility, acceptability, and quality of TB diagnostics, treatment, and services in these same countries. And third, the limited participation of TB-affected communities in the planning, implementation, monitoring, and reviewing of TB programs. You can read a little bit more in this peer-reviewed publication that I've linked in the slide, which looks at in more detail some of these related barriers. But now that we have this evidence, what is clear and what's needed for action is very much aligns with the global plan to end TB, which calls on all TB high-burden countries to develop national, costed TB CRG action plans and to integrate and implement these through national strategic plans. Secondly, that there is a need for a TB community-led monitoring approach, which ensures constant real-time reporting of human rights-related barriers and generates a response from communities and national TB programs to those identified barriers. Here is a little bit of that analysis of some of those human rights-related barriers that Challenge Facility grantees, so the communities and civil society on the ground in high-burden countries have identified, together with national TB programs. And those same issues, the types of issues which community-led monitoring can play a critical role in helping to both understand more, build evidence on, and sort of focus responses towards. In this little snapshot of just the experiences of 10 countries where there has been community-led monitoring, you can see that there has been a significant increase through community-led monitoring of community engagement, of peoples engaging around issues of human rights, but also around triggering responses to particular barriers that are inhibiting people's access to the TB services that they need. Community-led monitoring for TB is something that is relatively new, but there is now an established TB community-led monitoring approach. TB community-led monitoring is clearly unique and nuanced, and as such requires a unique approach. It is an approach that empowers people affected by TB to claim their rights, to access health and support services, to report and mitigate stigma and discrimination. It facilitates a community response to these issues that are identified and found by the communities themselves, and it can be integrated into existing data systems of the National TB Program, whilst, of course, ensuring data privacy of users. TB community-led monitoring has been adapted and piloted now in over 20 countries. And for TB, in support of overcoming human rights barriers, generating demand for services, and accountability, community-led monitoring will be a critical tool as we look forward in terms of scaling up community-led monitoring, making sure that it is mainstream at national, subnational, and local levels, and it is a featured component in national strategic plans in their subsequent M&A frameworks and budgeting. I guess the takeaway message that I'd like to leave you all with is that we must close the funding gap for TB communities. This is the only way that we can ensure initiatives like community-led monitoring can be scaled up to the levels that they need to be. And it is through mechanisms like Challenge Facility for Civil Society that we can help to do that. Thank you very much for your time.
Hello and welcome to this session organized by the Elizabeth Glasser Pediatric AIDS Foundation, EGPAF, and Treatment Action Group. This session has tried to highlight the critical and the broad range of roles that civil society organizations and communities play in reaching the national, regional, and global targets for TB elimination. And we want to thank you for your interest. And I just want to just have a few top takeaway messages from all our speakers that you've heard today, and who highlighted the importance of civil society and communities at the ground level. Keto Angami from India talked about the UNITAID supported Impact for TB project that his organization has implemented in the northeast part of India. And he talked about TB preventive therapy and how they have invested in building the capacity of communities at the field level. And we also heard from Democratic Republic of Congo, from Papi Jibu Tishikani, who is the care focal point at EGPAF. And he highlighted that civil society and community involvement in childhood TB is essential for policies and guidelines, for them to be updated, for them to be unpackaged, for monitoring and improvement of service coverage and access for people at the ground level, and also to address the inequalities on the ground level. Then we heard from Edna from Kola in Malawi, where she talks about the need to increase investment, especially in women. You know, how women have to, taking in their role as primary carers in most of our environments, that partners and governments need to support treatment literacy and invest in building the capacity of women's groups at the ground level. Finally, we had James Millar from Stop TB Partnership, and his key messages are that if we want advocacy capacity, demand generation, and community-led monitoring, that it is important to invest in communities to be able to build capacity and implement these activities. And he also talked about how in 25 countries, CLM, that is community-led monitoring, has been implemented. And he calls for the next step to ensure that this can be scaled up. So from the messages from all the speakers, we know that without community engagement and civil society organizations' engagement, our policies and efforts to end TB will perhaps leave a lot to be achieved, and we will not reach our targets in time. And it is important to invest in communities, because investing in communities actually means investing in saving lives. So I just want to thank you very much for attending this session on demand, and on behalf of the organizers, thank you all for joining us.